good afternoon once again. And I'm absolutely delighted that Dr. Ranga Krishnan is here with us as he shares his presentation, Innovation in Medicine and Healthcare Delivery. And he's going to provide his perspective. And we have been literally having a series of discussions with him, and it has been, to say the least, a very enlightening and incredible experience, incredible knowledge, insights. Ranga, thank you very much. So we launched this distinguished lecture series last fall to highlight research topics that integrate efforts by multidisciplinary teams. As we all know, biomedical science research, and in terms of biomedical research enterprise, has become a pretty large, complex endeavor and what I call a team sport. And it requires different subject matter and technical expertise, including many areas of basic sciences such as cell biology, molecular biology, systems biology, all the way to machine learning and artificial intelligence. Given this reality, and also, it requires a massive integration of, what we do in the laboratories to what we do in the medical school to what we do in the, healthcare setting. So it's basically, we're talking about bench to community type of, endeavor. That's what academic medical centers have become. Given this reality, it's highly essential to expose our junior faculty members, students, residents, and fellows to lectures and seminars on research topics that integrate efforts from multidisciplinary teams that have worked and are working together to solve a major scientific problem. So this lecture series will lead us to develop further insights into building successful scientific teams and new ideas about diversifying and expanding our research and clinical care programs at all levels. It's absolutely my pleasure to introduce our dear colleague and my boss, Executive Dean Rosenblatt of the College of Medicine, and he's going to make some welcoming remarks. Mark?
Well, thank you so much, Dean Prabhakar. It's a pleasure to be here in person with you all, and also clearly there's some folks joining us online. And earlier, as many of you know, we celebrated the College of Medicine's Research Forum, a research day, just to acknowledge the outstanding work of so many young researchers in our College of Medicine and to give them some awards. Thanks to Dean Prabhakar, Jackie Berger, and others who were so important in making this forum happen. It was across all of our campuses in the College of Medicine, well over 200 submissions, and really just outstanding. As I pointed out to some folks earlier, a quarter century ago, I actually was in charge of running a research forum in Miami, where I was a student, and it's a lot of work. And this, however, is very important in launching and supporting the careers of so many young researchers. And of course, this fits, it's very apropos of today's Dean's Distinguished Lecture featuring Dr. Krishnan. This lecture series is really to engage our College of Medicine, to bring in really the experts, the leaders, those who made seminal contributions to science and medicine, to interact with our faculty, our students, our college as a whole. And we continue to host these series and look forward to nominations from those who'd like to bring folks in your disciplines to the College of Medicine as well. We're so fortunate to have Dr. Krishnan, who's really an exemplar of excellence in academic medicine and healthcare. I've had a chance to speak with him a little bit over the past couple of days. And this is a remarkable individual who is equally facile at describing novel molecules to restore and improve mental health, to describing ways in which we might push healthcare forward across national healthcare systems. And really just to have that depth and breadth in such a wide varying areas is quite unusual and tremendously impressive. It's also very fitting that we have, in addition to his expertise as a leader in geriatric psychiatry, to have our own geriatric psychiatrist in this rarefied air in academia, to introduce more formally Dr. Krishnan, Dr. Anand Kumar, who's a Lizzie Gilman professor and head of the Department of Psychiatry. His outstanding work across geriatric psychiatry and Alzheimer's and in late life depression is impressive, funded through the NIH, many high impact journal articles, but which is perhaps even more impressive is his ability over time to build really one of the nation's preeminent academic psychiatry departments. His commitment to mentoring and commitment to nurturing programs of excellence is tremendously impressive, and we're so lucky to have him. So please, Dr. Kumar, to do the more formal introductions.
Thank you, Mark. It's a great pleasure for me to introduce Dr. Ranga Krishnan. I've never called him Ranga Krishnan before. This is the first time. He was always known as Ranga to students who knew him as high school, pre-med medicine, etc. We were in pre-medicine in Loyola College in what is now Chennai in India. It's been a while. The city has changed its name. Went to the medical school. We were in the same class. We came to the United States roughly at the same time. I came in 1982. Ranga came in a year or two before that. He did his residency in psychiatry at Duke. I did my residency at Michigan. We started off with an interest in the HPA axis, cortisol, depression, etc. I moved on to PET scanning and Alzheimer's disease. Ranga moved on to MRI research in late life depression, the Alzheimer's interface. We didn't sit on the same NIH study section, but sort of parallel study sections. He was in what was then called BDCN6, that's Brain Disorders in Clinical Neuroscience number 6. He chaired that study section. At the same time, I chaired BDCN1, which was formerly Neurology A. So a lot of common things, obviously. Background and sort of scientific interest, went to the same conferences, etc. He became a chair at Duke much before I became a chair here. And he helped stabilize that department. It was a good department going through a rocky period, as often happens. He helped stabilize and sort of harmonize, if you will, the research, clinical, and education components. And then, after gathering a lot of experience in administration, he moved on to a major international venture, which was the Duke University, National University of Singapore Medical School. This was a school that started from scratch without any prior preconceived notions as to how a medical school should be run. And he took the lead on it. Faced a lot of, I think, initial skepticism, if you will, from the community that is this even possible? But he spent a decade there. And the school, which I think, from everything I know, integrated the best elements of education in the West and the United States, and the best elements of education in Asia and Singapore, is among the preeminent schools today, at least in Asia. And by objective metrics, I would probably say one of the handful of schools in the world. It's perhaps less well known here, but over time, it's that hybridization of techniques and concepts that I think that really work. I moved to Chicago before he did, and then he moved to Rush. And this was not pre-planned, trust me. When we were sitting in pre-med, we didn't say, well, one day we'll end up in Chicago. And he was dean at Rush for a few years, and then CEO of the health system, which, as you know, is a very broad system. In addition to the college and the Rush Hospital, it has an extensive network of healthcare systems, clinics, surgery centers, hospitals in the community as well. He's been very successful as that. And he is one of the rare individuals, I think, who can see academic medicine, not just as a college of medicine that teaches and does research, but part of an academic medical center, and then which is part of a larger healthcare system. And I don't have to tell the audience here, these are complex times. There was a time when there was a college of medicine and there was a hospital. And for most cases, the dean ran the hospital, sometimes actively engaged, sometimes dean was the titular head. Then we moved into medical centers. They combined the two, and there was a CEO and there was a dean, and sometimes a vice president. About a couple of decades ago, all these became health systems with a sort of a nucleus, with the main teaching hospital, and then a lot of suburban satellite hospitals. And he and I have talked over the last year or two, many sort of informal conversations on where academic medicine fits in all this. What is the priority of the healthcare system? Is it making a lot of money, which clearly is important, or is it also cross-subsidizing education and research? There is no single answer to this, as you know, no one approach, and each institution faces its own pressure points. But he has done outstandingly well in this, trying to harmonize these disparate elements at Rush. He stepped down from the role about a year ago, and now he's busier than he used to be. He's being asked to start schools in India, in China, etc., trying to emulate the Singapore model. In Singapore, he was appointed recently honorary citizen of Singapore. My understanding is that's a rare privilege in Singapore. And this is testimony to the kind of work that was done and the outstanding medical school that he's pulled off, despite this being a novelty. And there's no clear precedent to setting this. I'm very appreciative that he chose to come here today and sort of spend a lot of time with the faculty, the Prabhakar, Dean Rosenblatt, and others. And hopefully we'll have, continued contact, whether he stays on in Chicago, moves to North Carolina, or moves to Chicago, or moves to Singapore, all very options. He's sort of the global citizen, if you will. But it's my privilege to have known him for all these years. And thank you for spending your day with us.
Anand, thank you. I never know what Anand was going to say, but when you know somebody for 40 plus years, you never know what someone can say or know about you. But thank you, Anand. And Dean Rosenblatt, thank you for inviting me. And Prabhakar, nice to meet you, and thank you for having me over. It's been a pleasure to meet some of the students and the research presentations and the posters that you had. It's always impressive. It's a time to, whenever you look at where we are in healthcare, everything goes like a wave. There is a period of time when everybody is really positive, enthused, money is flowing freely, and suddenly something happens and money goes down, everybody is worried, sky is falling. And we're entering that period, sky is falling. What I'm here to tell you is sky is not falling. We'll come through this. But I also want to give you an idea of where, and this is not putting it lightly. Every decade or 20 years, there is a phase that comes in where there is going to be a lot of change. And change is always a little bit anxiety provoking, but there's also an enormous opportunity that comes in. So what I want to do today is like lay out a big picture. I'm not going to get into details of any of my research or others' research, because that I don't think would be valuable for a broad audience. But I'd like to give you a big picture of where I see things. And some of it is I was very fortunate in different roles that I've worked with governments, the private sector, academic institutions, literally both in the US, a little bit in England. And what I can tell you is you can have the same problem, but the lens in which you see it can be very different depending on which perspective you have to take. But the problem is still the same. The elephant is still the same. It's which piece that you choose to look at that varies. But I'm going to try to give you a big, broad picture. And then hopefully I'm watching the time. I'm going to go through like a fly through and then open it up for questions and discussion, anything you want to ask. And let me do it in a quick, I'm not going to give you a 30,000 foot view, but I'm not going to give you a microscopic view. It's somewhere in between. And it's going to be broad ranging from the science to what really matters to people, patients, countries, and systems. So that's the scope I'm going to try doing. So the perspective is both on health and healthcare delivery. And I'm going to talk a little bit about some macro stuff and some micro stuff. So one thing we all know is the population is aging globally, particularly in the developed world, but you probably are seeing what's happening in China. The aging of the population in Asia is dramatic and happening really, really fast. What does that mean for health, healthcare, economics, and populations? Second, I want to talk to you a little bit about an optimistic, exciting time to be in medicine. Then I want to talk to you about something that you see every day. We're actually in the middle of it every day, and we don't even fully realize what it means. Big data. Going to talk to you about healthcare demand, healthcare cost, and the connectivity between retirement, reduced workforce, a little bit on COVID, and why we need to change how we teach and why healthcare systems are going to change. I'm not even saying why we need to change. They will change. It's a question of, do you want somebody to change it for you? Or do you want to be changing it before somebody changes it for you? So that's the broad outline. So it's a big one. So this is just to give you a population change. Look at what's actually happening over time. What you're getting is a rapid increase in the population that is aging. What you're going to see is the population in between is going to become insufficient to manage the people who are going to retire and age. So this has got a term attached to it. And the term really is 18 to 64. Obviously, all these are rough parameters. Is a population that has to support people below 18 and those who have retired. When that ratio shrinks, and it is shrinking really fast everywhere, including the US, means you have fewer people making money or economic GDP to support the others. That's happening today. It's been happening for a decade and it's accelerating. And there are very few ways to solve it because you can't ask the population to have more babies. That thing doesn't work. Every country that has tried it hasn't worked. You can make it a little bit better, but you don't hit the replacement ratio 2.1. In many parts of the world, it's now 1.3, 1.2, dramatically low. So keep that in mind. Second thing is this one. This is particularly relevant to the US. I'm hoping you can see the slide. The red one is the number you want to look at, which is life expectancy. And on the other axis is the healthcare cost. You can see healthcare costs are continuing to go up dramatically compared to other countries. We're way outside, even the most developed countries, but life expectancy is going down and going down every year now for a few years. And if you project out, and you can project it because the population that is dying at a higher rate is the young to middle, 18 to 34, 18 to 45, depending how you want to count. So that's going to trend further down, and life expectancy reversal in the US is going to take some time. I can't tell you when. It's a key question. It also depends on what the country does as a whole. When I say country, it's not about government and policies, it's people. It's all of us together. So with that as a background, I'm going to go through a few things on times of excitement, new discoveries, new therapies. You're going to see it literally every day because there are more things that are coming up, going to the FDA for both diagnostics and treatments. The diseases that we conceptualize when I went to medical school are not the diseases of today, because not that they changed. Now that we know more, they're getting more specific, more personalized. That categorization is going to dramatically increase as we know more. Okay, let's keep that in mind again. The second is the number of new therapies based on much of what we have understood in the last 40, 50 years. Nothing of these therapies have come in isolation. They are the result of a lot of basic fundamental research, and we're beginning to see the fruits of that. Whether it's oligonucleotide therapies, there are 3 of them coming in, CAR-T, which you have heard about, chimeric antigen receptor therapy for cancer, 2 of them, and now several in testing. Transgenetic therapy, a couple of those with the adenovirus vectors have already come in. Gene editing, rapidly being tested in humans, coming in. Universal donor cell therapies coming in. mRNA therapies coming in. And these are right now in much more of the smaller population rare diseases. But it's gradually going to move into bigger populations. Because not that the bigger populations are going to get one treatment, but they're going to get more specific as you can take the particular category of patients to particular therapies. This train has left the station. There are about 300 plus, 320, 330, literally every single day when I look up, trials of these things are going on in the US and globally. By the way, this is not a US phenomenon, it's a global phenomenon. Okay. The problem with all this is scaling it up. You can do the research, you can scale it, but how do you actually pay for it? How do you actually deliver it consistently? Remain big, big problems, manufacturing, engineering problems. Example, CAR-T came out mostly for liquid cancers a few years ago. Now there's a whole bunch of them for multiple myeloma, other cancers, solid tumors. The results are getting very impressive. But they're also moving from that to autoimmune disease like lupus. And you can just think of the number of potential approaches as variations of the same approach are being built. Same thing is true with mRNA. You have heard about it for COVID. No, not many people knew about it. When Sidney Brenner started working on it 40 plus years ago, even he used to be also Singapore-based when I was there. This never was in the possibility at the time they started. It was pure question, pure fundamental research. Now is one of the hallmarks of the types of medications and therapies, from cancer to vaccines to all kinds of things that are coming about. Fundamental discoveries leading to an enormous outpouring of turning those things into applicable things for humans at scale. Problem, cost. The other big area is big data and AI. By the way, I don't like that word, AI, because I think we use it to mean both artificial and intelligence. It is neither, okay? It is not intelligent by itself. It's what we make and do with it that makes it that. It is artificial, yes, but it's algorithmic to begin with, self-learning to go to, and it is going to continuously adapt. And you're hearing a lot more about it, but the background of this dates back to the 60s and 50s. This is not something brand new. Some of the work that I was involved with was in the 80s with artificial neural networks looking for objects in radiological scans. And even then, we could do it. The problem was we didn't have the computing power to do it. It would take several days to find one piece of information. Today, it's in seconds. Okay, that's where things have come. So the other parallel thing is the rapid translation because of the development of technologies, all kinds of technologies that have come in. We've always had lots of information, but we never had access. Now we have access to tons of information, some that we recognize, some that we don't. One of the things that we probably don't is how much information about each one of us is known, not to us, but the people who are using it to tell us what to think, what to do, what to buy, what to feel. 20 years ago, Google wasn't around. You didn't have cell phones around. Okay, now you can't live without them. You're all addicted to them. But Google and search engines tell you, based on you, what you should look at, what you see, what you should think in a way. That's happened, by the way. You can't change the clock. It's happened. It's going to continue to happen. And it's continuing to learn. Every time you use it, it's learning something more about you, but not just you, but everybody else. That's what it was designed to do. And it works pretty well. So we have lots of information from your phones. And now that you got Fitbits, Apple, and everything else, it also knows your physiology. It knows what you look like. It knows what you eat, literally, because it knows what you're buying. And it knows what you're walking, where you walk, and you can use it to start predicting things, whether you can predict to the individual level, not yet there, but you can predict at an aggregate level. So that's one part, that is extracting information and being able to use it for giving you other information. But it's going to move further along in what it does. It's seeping into it, and before you know it, you have Siri, you got, I don't know, Alexa, you got Google, and now you're hearing about ChatGPT-3. None of these came in isolation, by the way. All this is hundreds and thousands of people working to make this happen. And it's coming at an enormous speed. And just like Google and Apple, you can't live without it. You're not going to be able to live without ChatGPT and others in just a few years. It's coming into your daily life in every way. It is already in. We may not fully recognize it, but it's already in. And we use it, whether you're doing travel, whether you're going to go look somewhere, whether you're going to a restaurant, you're using it. It's part of our everyday thinking. If I ask you to remember your wife's telephone number, your husband's telephone number, very few can do that without their phone because it's all inside your phone. When you lose your phone, you're lost. That's actually where we are, okay? Because our brain's memory storage that we need has gone down. So ChatGPT is actually just a language model. It's extracting tons and tons of information, putting it together and creating new things. Have any of you tried ChatGPT-3? Yeah. So if you're a student and you wanted to take your USMLE, it might pass it for you. In fact, they've done studies to show it pretty much gets you almost there. Okay. What does that mean? Because most of the exams we're doing are knowledge and information and fact-based. They're not necessarily testing your ability to turn it into applications, but ChatGPT has more access to more information than you can ever hold in your brain. You can see it gradually performing better and better. So it raises issues. Where does ChatGPT, by the way, that's the only one that I'm talking about. There's tons of them happening at the same time. There's going to be plenty of competition in that field. But it tells you we're in it. We don't know its implications. We can guess some of those implications, but it also raises issues that we need to be aware of. Just like Google and others have changed our thinking patterns, how many of you use Facebook, Instagram, WhatsApp? Just look at, if you look at the number of hours and minutes people spend on those things, to the number of hours you spend on anything else, it takes up more of human time than almost anything else. If you have anything that you don't have time to think, you want to use it to find what somebody else is thinking about you. Or you want to get somebody to know what you put out you like or don't like. That's us. It has changed us. It has changed our brains. You're seeing it with music. Pandora was now several years old. All it did was people pulled together and said, these are the things. Musicians said, you like this. These are the other things that it ought to like, and it can pull it. It's beginning to turn it from sound. It's now gone much further ahead than where it was, because it's self-learning. It's using data to continue to learn. You all know about Tesla and others. They do drive, the self-driving, but you also know the issues when you totally rely on it. You hear about accidents. What you don't hear is a converse, probably better than humans in some way. Most humans, not all, but it's that average part that comes in. But it can also make mistakes because it's still learning. And it's also still got issues. We don't know all the issues because it only happens, then you learn the issues. We learn the same way, by the way. We always presume things till something goes wrong or something happens, and then you go back in and say, well, let me find out. Hopefully, we still retain that ability to look when something goes wrong or something new happens. Healthcare information, a few years ago, it's 15, 20 years ago, there was no real electronic health records. Everybody kept notes. And electronic health records, when they first started out, was a way to collect more money. They've gradually started to change as they collect more information. They're still not turned into the point where they're used for the purpose of delivering care. Imagine how fast that's going to happen as systems come in and what the issues would be. We've got lots of data that's coming in. Some of those precision medicine, NIH actually has got a match program trying to match people to clinical trials based on your genomic data. It's already out there. Cancer is one of those fields that's rapidly moving in because precision therapy is becoming a real reality, rapidly coming in. It is no longer a question of a clinician seeing just a patient, making a few educated guesses, and trying a few things and doing it. It's still there. But a lot of it is also being driven by enormous amounts of data saying, these are the things based on the genetic. It's not just so the diagnosis of cancer is no longer a clinical diagnosis or a radiological diagnosis. It's a composite of a lot of things, many more things to come in with transcriptomics, metabolomics, proteomics. We don't even know how far these things are going to go. But cancer, like viruses, also adapts, by the way. You can target a cancer with the most precision therapy, but you're not going to kill all the cancer cells, and there are going to be a few of them that will survive and grow again. We are learning that as we go further forward with these therapies. Like we did with viruses, COVID was a great example. Whatever we predicted on mutations hasn't turned out that way. It has been, I'm calling it or making it a person, but it isn't, but it's adapting, constantly adapting, because its nature is to do so, as the virologists in the audience can confirm. Every time we think something, it does something we didn't expect. And whatever antibodies we're throwing at it, it's adapting. Automated screening, as your dean will say 15 years ago, was a pipe dream. Today, the reality, it's FDA approved. I don't know how many of them are coming in. Each has its own strengths and each has its own weakness. If you move it from one population to the next and you didn't test it, it could throw out a few things that you didn't expect. But it's there. And I was told earlier today that you're going to, I think your CIO is saying, is going to come into your screening systems. So once it comes in, you're going to have to learn, what does it mean for you clinically? How does it work in a work environment? Because one of the hallmarks of all these things is humans like to not have to waste too much energy. So if it gives you a prompt and you don't think and just follow the prompt, at some point, the prompt is going to be wrong. How do you know and how do you think? Because otherwise, the computer may itself press the button and tell what to do and give out the prescription and doesn't need you. That's not what you want. And I don't, just like Tesla is trying to say, keep your hands on the steering wheel. I'm just using it as an example, by the way. I don't have anything for or against any of these things. But I look at every one of this as telling us a lesson. And that's the more important thing to keep in mind. Apple Watch and its EKG, and now there are tons of them, they're getting more and more accurate. Okay, but they also have false positives and false negatives. There's nothing in the world that is perfect, but it's better than nothing. And it can be very, very helpful, but you need to know how it works, how do you integrate, how do you put it into a system, and what are the hallmarks that you need to keep in mind. Comes back to something I keep telling about, you've got to think. We are designed to think, and if we lose it, we'll have a problem, which comes to this. The electrical activity in your brain reflects to a great extent what's happening in it. Many years ago, this is the one thing I'll mention about my more recent research is back in Singapore. We started a program on brain-computer interface. It's almost 15 years old now. And there were a few things that were eye-opening for us. First is we could take the EEG and use it to drive computer systems. Second, we actually learned something we didn't expect, that you can learn to turn on specific EEG elements to type letters on a screen. So in other words, you are using your brain to produce a signature to do something. Think of it that way. Instead of the brain designing it one way, you are inputting something to do it. This whole field is rapidly changing, and back at Duke, Afui Dizurasa and Miguel Nicolelis have been doing implantable electrodes. Now they're getting into humans. There are several companies going in. There are lots of ethics around this thing. Because it's no longer a one-way communication where you're taking signals out of the brain. You can actually interfere with those signals. You can put things in. Kafui and his group is actually building an entirely new synaptic system with connections. So in a sense, he can create artificial brain circuits in living animals. Okay. Now that is a way of changing thinking, changing behavior, changing motor inputs. So all of these things are great things, great promise. There are also risks. There are also issues. There's no such thing as perfect things that are always going to be positive. So you need to know, especially as students and faculty and academic institutions, is the ability to question, to think, and not just assume that whatever you're being told. EchoMD is another program really being very quickly used out of Minneapolis. It can look at video clips and tell you which ones should you look at for calculating EF. Very, very accurate. It's a supplemental system. So you can take it and then use it. You're going to see more of that. They're not going to total replace, but supplemental things coming in. Personalized cancer, multiple entities doing it. Radiology, pathology, and ophthalmology, which are visual things, are where visual processing has gotten so powerful that they're getting better and better with 80, 90, and I think you said 95+% accuracy. So imagine that. So they can beat a non-specialist at this point in many conditions. Okay. Some point they may get close to a specialist. Some point they may exceed one because of the ability to process massive amounts and use a massive amount of knowledge to process it against. But there are risks. Patient flow optimization, airlines do it all the time. It's coming into patient care very, very quickly. So this is something we started back at Duke when I was chair. We built an electronic health record, which is database, rather than dictating or typing in. It was totally database. We had it running in multiple mental health centers for psychiatry, built by somebody called Ken Gersing. What it actually did was provide us accurate information on symptomatic levels of patient, provide you whether some medication or therapy worked or didn't work. What did doctors do when something didn't work? What did they put on top of it? And in that system, what happened when somebody took this but not that? So problem is then we started to say, let's show it to people. And then we ran into the familiar thing that people started to not want to think. So whatever turned up, people would start to go that way. That was when we turned it off because I got concerned for many reasons that we were taking out. And by the way, when you do that, the system and its knowledge changes because you now change the data because you've actually influenced everything in a different way. And by the way, if you think about it, it's happening every single day in our daily life. None of us is immune from what you're thrown at every single day. It doesn't matter whether you're a mathematician, statistician, or a scientist, or a layperson. Your thinking is changed by the amount of things you get, how you interpret it, and it is biased in your direction. It is designed to go with your bias. It's very hard for you to go against your bias because you have to make a lot of energy and effort, which is what I'm trying to say. In healthcare, We owe it to our patients to make that effort. So implications for training, we really need to know how to teach students to define things, to translate things, to compute things. I'm not asking you to run programs, but to know how it works and how to be able to interpret, which is the hardest thing to do. Our traditional medicine and training has always been attempting to ram as much information into your head, test it in exams, hope that you can keep that for a long period of time and hope you'll use it. We know the human brain doesn't work that way. Okay, we know it doesn't work that way. You only can remember a certain amount, and if you don't use it, it fades. The computer doesn't fade. So we have to think, how do we use the strength of these systems against what we can do better versus what the computer can do? How do you integrate that? That's where we are. I'm not telling you there's a solution. I'm not telling you exactly what happens, but what should a machine do? We can do all these things today in different environments, less so in healthcare, but it's coming in. Machines can work in an operational environment. They can observe, they can represent, they can even infer within limited structures, what is called restricted structures. They can predict within restricted structures. They can even plan, and if you want, execute, which they do in the robots that you're saying that Amazon does to get your stuff to you. Okay, it's happening in real time, but the humans still need to be there to know when something goes wrong. That's part of what our training has to focus on. We already have seen examples. You hear about car crashes, you know about plane crashes, because the planes have gotten that way. And this was, I think, the Airbus, if I remember right. One of them went into the ocean. One of them was when I was in Singapore, an Air Asia flight went into the Straits because the pilots, the computer was telling them something and the pilot could not recognize that that was an error. Okay, this is going to happen. There's something else that we need to keep in mind because this comes in the context of what data goes in is what the computer is doing. Something called FAIR. You're going to hear, I'm not going to get into detail. This is findability, making sure the right information on the right people at the right time is there. We don't have that. It is very much centric on populations that have resources. It is not centered on populations that don't have resources, and applying it there is going to lead to some fundamental errors. Accessibility. There's going to be haves and have-nots if we don't watch for it. There is going to be a problem with interoperability because our systems are siloed. It's not just healthcare system. I'm just talking even in very broad sense. And reusability remains an issue. Again, lots of details. If you pull up FAIR, you will read a lot about it. It has lots of implications for some of the things we're all interested in, diversity, equity, and other things. It's very critical, something we can't ignore. You're seeing it in facial recognition, where it turns up, but you're going to see it elsewhere. It's not just faces, it's everything that it plays a role. Emerging infections, I'm going to use this as a story. So when I went to Singapore, one of the things Singapore had come through was the SARS virus. Okay, but we're all humans. After we come through an epidemic, we forget. That's our brain. Our brain is designed to not look at the next one. We are designed, oh, we've come out of it. Great, we need to get on with our life. So the question is, how do you convince people the next one is coming? Fortunately, in Singapore, we were able to do that. We created a BSL-3, which is a high-level security lab for viruses. Most of these viruses live in bats. And if you haven't seen a bat, by the way, they're all around you. They're in every city, every part of the world. And bats contain viruses. The immune system of bats accommodates viruses. They've evolved to let viruses stay in them. Now, when a bat bites an animal or some other way bat fluids contaminates an animal, viruses can go across. And usually it's an animal problem. You're right now saying, and by the way, why do your egg prices go up? Swine, the flu, bird flu. That's been around, okay? You're going to see more of those waves come through in animal husbandry and elsewhere. We had swine flu when I was in Singapore. We had bird flu. It crosses over into humans. The key is cross from animal to human, zoonotic viruses. When they cross, you never know when it's going to spread. It is just random odds when it's going to happen. I would propose, and this is why we put up an effort, is it's just a question of when, not a question of if. It's just more and more likely, probably a variety of changes, climate, population density, movement from rural to urban, population density between animals and humans, because we're going into where animals live. All those things are playing a role. Happening a lot, Asia and parts of the world. That's one of the reasons why I put this together. It's called emerging infections. Every year, a few viruses cross over, most of them in a village, and they go. Some point. And what happened with COVID was you got that right virus. It didn't kill as much. It just was in the right transmission, but it infected you, and it's constantly adapting. Okay? And we can only do so much with these things. Singapore, because of the planning, many, many factors that they put in, they had a National Center for Infectious Disease with the BSL-3 program. These are raw numbers showing you how they were able to manage and keep the death rate down very, very low, because you plan for it. Anytime you can plan, you can do a lot of things. The other factors, the younger population than the US, and the healthcare system is heavily weighted towards prevention. And masking and all that is very common in Asia. So when you tell people to mask, and I just noticed everybody's starting to mask, but okay. Obamacare, access. And this, you all know the genesis of it, is really to get more access and reduce the cost, remove the impact of pre-existing conditions. And it did what it's supposed to do. But healthcare expenditures are continuing to rise, and the premiums are not going to be sustainable. You can see the graph at the right. Just look at that thing, how fast it's going. And look at it relative to earnings, which is the second set of graphs. So that divergence is massive. We're spending $12,000, $13,000 per year per person. If you add all those new therapies we're talking about, we can estimate 15, 18, 20, 21,000, more than the salary of people you're going to pay. How do we play a role in this? How do we mitigate that? And this is connected to what I first talked about. The support ratio is changing. The national debt is going to grow because you're going to have to print more money when your support ratio is going. Senior population is doubled and doubling very fast. And also when populations get more wealthy, number of children goes down. I've seen it in Asia. The trend has been dramatic in China. It started with a good intention, one child per person. Then you suddenly can't reverse it, by the way. Human behavior doesn't change that way. You can suddenly say, have 2 kids, which they did, then have 3 kids, which they did. Population hasn't budged. It's continuing to go down fast. You're seeing it in the US. You're seeing it everywhere. We're well below replacement ratio. It's an intergenerational tsunami of how do you support those 2 age groups while we go through it's a tsunami because the wave that's running through. At some point it stabilizes, depending on which country you live in, somewhere between 2045 to 2080. Big range. And by the way, one of the people who predict things very well, the group, is the demographers. They have been right on the money for a long, long period of time. That's the one group, because the amount of data they have can predict reasonably well. This is just to say, yes, we have solved the problem to some extent of coverage, access, but there are problems. Healthcare expenditures getting close to 1/5 of the economy, and high deductibles, basically meaning you're going to have to pay more to get in. That creates an, again, equity problem. And enrollment, the healthiest don't want to keep paying because it has to support everybody else, come back to the support ratio. And the rules have become extraordinary. You don't have to be in healthcare administration to know. If you look for your own healthcare, figuring it out is extraordinarily complex. You just go type in the cost of a drug, any drug you want, and just ask for how much it costs if you're paying in cash at which pharmacy. For a drug that I was looking at yesterday, it ranged from $330 to $5 within a less than 2-mile radius. Okay? And how many of you comparison shop to know where to go? None of us even think of it, but it's here. Other related trends, because of that, people think larger is better. I don't think it is, but everyone is consolidating. We're also getting quality transparency and commoditization of services. You're getting CVS, you're getting United, everybody getting into primary care. Why? There's an extension of the pharmacy in many ways. Now that is also going to create some issues in the academic health center. How do you connect? Because as you create these things, how do you connect everything together to provide value? There are some major intersecting trends. These are macro trends. They are pretty much clear-cut. Aging population means workforce shortage because people are going to retire. Aging population means more demand for people to provide the healthcare. Not just pay for it, but you need more people. Cost pressure, you're seeing it today. We are attempting to distribute and decentralize and produce remote healthcare delivery, but we haven't actually figured out how to do it and monitor it. Clinically integrated networks are all coming in, but if you fall into one network, it doesn't mean you can easily cross over into something else. It's creating its own set of issues. One thing you may or may not know is we all depend on the hospital as a source of revenue to support an academic place, to support the dean's office. That's changed. Why? Inpatient admissions are falling, both in national, Illinois, and the change is pretty fast. And every drop changes how much revenue comes in. And you can see what's also happening. The yellow is outpatient utilization going up. The red is the inpatient utilization coming down. This is only up to 2013. I haven't got the new data. The trend line is actually accelerated even further. So it means whether we like it or not, academic centers are really good on the more severe hospital side of it. That's what we were built. But that's a declining part as things move to the outpatient, where it's a different business model. That's created other issues that we have to tackle. Medicare Advantage, you see the advertising when it starts around September, you're inundated with it. And when I turned 65, I don't think I could not figure out how to even look through those plans, because I was getting email after email selling me on each one. And I'm looking at it and saying, I know this space and I can't understand. Okay. And the reason behind it is as that shift is happening so fast, what was 21% in 2017 is already more than a third now, heading towards 43, 45%. Now, what Medicare Advantage does is it changes the cost structure that you're going to get reimbursed. And when it changes, because something has to give when it's the same amount of money. And when that happens, that creates increasing fiscal pressures on systems. And you're seeing it today. You're seeing so as I have had multiple roles between governments, academic health centers, CEO of a system, a dean, and the chair, I can see it now from every angle, and it's the same elephant. It's the same set of issues, but we don't tackle it that way because the incentives are aligned in different ways. And it's only going to happen when we all join together to solve it. That, by the way, includes patients and the population. You're not going to get any of this changed without engagement. It's not a physician, it's not a hospital, it's not an insurance, and it's not the political, it's everything. And we are not anywhere near this. This just to say what I just said. Hospital margins are going down. And if you talk to the CEO of your system, I'm sure he will tell you the same. So this brings me up to the last 3 minutes, if I can. I'm going to skip or fly through this part. Workforce and education. Just like healthcare, education has not changed. By the way, the school system and the way you're all seated, you can give credit to the Prussians. This was the Prussians who decided that schools should be set up this way. Somebody should sit in front, tell you what you need to know. You remember it and follow it. That's how the entire educational system has been for 150 years. Now, just like this room, I suspect most of your classrooms are empty. The students don't need to come. One of them can tape it or your video doing it. Already happened. Just that the institutions haven't recognized it. I think it's the same for test systems. Don't know if I'm. So I'm going to continue on this. So when we went to Singapore Fresh Start, so we said there is a science of learning. So why not use the science of learning? So the science, perfect. Yeah. The science of learning is based on whatever I told you now. Odds are when you leave the room, you're not going to remember, which is great by me because if I said something wrong, you won't remember. But the first 10 minutes and the last 10 minutes is the max that you're going to remember. Second, and by the way, this goes to a scientist long back, what's called a memory curve that was done. Second is the overload of information. It's massive. Third is this is the curve that I talk about. It's from Ebbinghaus. Classic curve showing how good your memory is. In 19 minutes, you lost about 50%. In 31 days, you're down to a little more than 20%. It doesn't matter what it is. The only way you're going to remember it is if you relearn it and apply it. So the entire approach we took is called team learn, engage, apply, develop. And it's all based on the fact your content, you can get the best content globally and put it on the web. Students come to class, we ask them to take a test. If you want to know, did they actually study it? You don't expect them to be able to answer everything because then they don't even need you. What you expect is a certain number to answer. Then what we do is if you teach each other, you'll learn better. So we put them into small groups of 8. We assess them individually, assess them in groups. When they teach each other, the learning curve goes to 90. This is called group. Then we take and ask them to take a complex problem, open net, open book, the real world, and answer that. But 10 to 20% of the answers have no answers, because that's truly healthcare. You don't know. What we want them to do is when you don't have an answer, how do I think to make a decision? And so that was the approach we took in the entire learning process. We sped up learning, by the way. So preclinical is all done in 1 year in this system. The anatomy they learn is anatomy you're going to use. The physiology you learn is applied immediately to physiology you're going to use. The biochemistry, the anatomy, and physiology are integrated. Completely different. Cost of education goes down. Learning curve, so went back to, goes up. This is the application phase. So this is something that many other schools are adopting piecemeal. Universities are doing it. About 100 universities use a format of this, including one of your UIC campuses. I think it's in Champaign that's beginning to use it. The purpose behind it, this is how students learn. They don't really want to listen to a lecture that they're not going to remember. They don't go there. They're already voting with their feet. So this is an approach to take it where the classroom is taken for engaging and applying and testing, not for a lecture. The lecture can be right on the web. How many of you actually would go to a lecture? I see it today, right? If you didn't have to come and you can watch it from your office or room, the only reason you come is the social aspect of it, which is extremely critical. I think it's one of the things we lost during COVID. Anyway, healthcare delivery, we're in the middle of a massive transition as we try to figure out how to get the cost under control. Transition is fee for service to pay for value. One of the greatest challenges we face. The solution is not going to be easy because all the incentives are not aligned. So it's less care for more value, not more care for more money. That's going to be tricky to navigate when everything for 100 years has been built differently. The data that you need, the systems that you need to do, in not just physicians and providers or payers, it's patients. It's a different system. To pull it off is going to mean a big problem when we have a silo in both payment and care. And by the way, to do this, you need data. Data is going to be the heart of all these things to pull it off. And that's hard to get. Niranjan ran a program to also imply that when we look at a disease, we think of it as a disease. We forget the person. A person who has a disease is going to have other issues. They're anxious, they're depressed, they may be taking alcohol or drugs. By the way, drug use is so common, 100,000 opioid deaths a year. It's not something we can live as a nation. Okay, we're going to deal with that. So this was something that you can ask Dr. Karnik to talk about it. But the basic approach is if you screen everybody coming into a hospital, a proportion of them will have drug abuse and alcohol abuse, depression, whatever. If you intervene very, very early, you can impact the length of stay. Impacting the length of stay pays for the whole thing. You're doing the right thing, but you're also being able to pay for it. And you can gradually extend, and I think Dr. Karnik is now extending it beyond the hospital doors to where it really matters. So this is to say, even in the current system of payment, you can work around to provide solutions which improve patient outcome and patient care, but it really requires making things systematic. And the data shows both on length of stay, cost, everything. And again, you should invite Dr. Karnik to talk to you more about it. It's just an experiment to show creative thinking can solve problems, even in the current payment systems. This shift to value-based care is happening really fast. There are different categories. I'm not going to go into details. And otherwise, I'm basically going to put everyone to sleep because it is quite complex. These are the programs that the CMS has authorized. Every one of these programs goes into pages and pages of what it is and what it isn't. Okay, how you get paid, what you get paid, what is going to be measured, and what happens if you break the rules. It's all happening in real time. And everybody is struggling how to put up with this. Many of these, your hospital and ours and everybody else is embracing. That's tough. to pull it off. It requires everybody to work together, including patients. In value-based care organizations, currently you have ACOs. I'm sure UIC has one. You've got patient-centered medical homes. You've got bundled payments. All three are here. That itself has created issues on how do you pay people internally. The population management is really this full circle from wellness to prevention to chronic disease to complex case, which means you can't say psychiatry and is paid one silo, drug abuse is paid another silo, and medical care is the third silo. If you don't treat the substance use problem and depression, they're not going to take your medicine. Compliance is well below 50% for lots of conditions, so many factors. Cost is one, people don't believe you, they don't understand what you said, lots of things. 50% means 50% of what you did wasted. The net impact is calculated to be 400 to 500 billion a year. The impact of not addressing that anxiety and depression is another 400 to 500 billion a year. I'm using B. Massive costs, but the silos prevent you from coming together. And that's one of the things that I think you're going to see those changes come because the need and imperative is high. People are talking about it, but I don't think people fully understand the complexity of where we want to go. We can sort of globally say we want to go, but how you're going to get there is a ton of issues. And with that, I'm going to say there's enormous research, enormous opportunity, enormous challenges, which makes it for young people coming in a great time to be in health and healthcare, because it's a great time to provide what you want. And the reason you come into healthcare is to provide better care for people, better outcomes. Opportunity is great, fun time to be, but there's also going to be times when you feel like the sky is falling. And the higher up you go, the sky falls faster. But the reality is the sky never falls. It's going to be there tomorrow. It's going to be there forever, at least for a few billion years. So with that, thank you for the invitation.
Concepts, products, but I think one of the Achilles heels is implementation. At a 30,000-foot view, can you share some of your ideas related to implementation?
So that's actually one of the challenges that I work with governments, because it actually involves getting all of them aligned. You can build any product you want, but if you don't get the patient, you don't get the provider, you don't get the payer, and you don't get the government aligned, including the regulations, it doesn't work. Lots of good ideas, there are tons of them, don't work because they forgot the patient. That's the number one problem, by the way. Second, they forgot the provider. If it increases the time of the provider in an already constrained environment, no matter how good it is, it ain't going to work very easily. If somebody is not going to pay for it, not going to work. And if the government doesn't want you to do it that way, not going to work. So one of the things that we have started to do, again, it's a little bit different in Singapore, is to get all of them involved from day one. So it's, in other words, co-develop, co-create. So you don't build a solution and think, great solution, but and then realize nobody's going to use it. You spent a ton of money and you're not able to get pick up. You're seeing it with so many things today because the cost factor has become so big. Or only a tiny proportion of the population is willing. They're more educated. The people with more resources use it. The people who really need it don't. Today, we're facing that for thalassemia. The cost of thalassemia treatment is $3.5 million, the new drug, per person, okay? It is cheaper than the lifetime cost of thalassemia for an individual, but your insurance system goes 1 year to the next. So if you work for UIC and tomorrow you work for Rush, UIC will pick up the cost, the benefit goes to the other institution. So we have massive challenges to think through these things, but I also am one of those optimistic individuals. We will overcome these challenges because if you see something really good, somebody is going to figure out a way how to get it out, but even if it means it's going to take a longer time. What we're trying to do, at least when I can get alignment, is to get everybody around the same table. So you don't build the solution before you have an idea how it's going to work. By the way, AI is coming at you so fast, but no one has figured out who's going to pay, how is it going to be used, what happens when it goes wrong, whose malpractice is it going to be, what are the issues attached to it, who's going to regulate it? Because AI, how will an FDA regulate it? Every day it's going to be changing. How do you regulate something that is changing? I wouldn't even say every day, every second. Okay? So we are facing those. And it's not that people don't know it, but how do you bring everybody together around the table, which is where academia comes in. We also operate in silos. That's our nature, because we're all individualistic and we are group-centered to our own groups. I think we have to start overcoming it because the problem is far bigger than any individual or individual group. But I'm also optimistic that I do think we'll come together. I've seen it happen in the specific areas. Usually when people tell me it won't work, I get very involved in it to try to make it work. Sometimes it works, sometimes I fail. But I don't take failure. I just take it as a next step in my, I'm very lucky that way. I try and people generally give me a chance to try, even though the odds of failure are always stacked. When you attempting to change things means you also have to be willing to take all the criticism, to take all the heat. And you have to be willing to not feel, if you're sensitive about what people say about you or talk about you, can't do these things. And unfortunately, we all are. That's our nature too. And I'm not saying that I'm not. I mean, I am too.
Dr. Krishnan, thank you so much. That was a terrific comments. I wanted to ask you, given that all of us here are an academic healthcare enterprise, and by very nature we have multiple missions here, education, and research, and patient care, among others, your thoughts about where, our problems, are they any different than any other health system in achieving sort of population health, or are there particular ones you think we should be focused on given our multi-partite mission?
So this is actually a more complex question, but let me try answering it. What has happened is because we haven't done so well. Academic health institutions have too many missions, and you're trying to balance a lot of things. However, people are coming in and saying, an academic health institution doesn't focus on the patient. Patients don't particularly, if they don't need to come to an academic health institutions, they're going to go elsewhere. We know it. Okay. And what happens is you got United Healthcare, you got CVS Aetna, you got lots of entities coming in to provide primary care at a more efficient, more easy services at a lower cost, because they can also cross-subsidize in a different way than we can. So you got that challenge coming up on one side. Healthcare education, just like education in general, has been codified and rigid because of the way in which we built institutions and the regulators of the institutions. No one is coming back and saying, what kind of professionals do we need to train in the future? What kind of, should an ophthalmologist, since the dean is here, should he have to go through the same training if you know he has to be an ophthalmologist? What are the things he has to train? Could we have streamlined pathways? Because what you do also when you train so long is the amount of years they have to provide the care has gotten short. And we don't think of all these things when we did it. We just throw more things. We never take things away. That's also human nature. So I would say some of it is self-inflict. And by the way, I've said this to other academic institutions. We have to look at the mirror ourselves. It's not somebody doing anything to us, but we collectively have done some of these that we're going to have to deal with. And the last part is the research side. We also live in isolation in research because we all love what we do. We believe in what we do. We're biased in what we do. We got to figure out a way where we cross-talk, cross-connect, and do things with the patient and the delivery and the cost as outcomes. We're going to get there. You have it in NIH trying to tell you to focus on that when you write your grant application. Right now, it's like a mark, but it's going to be more so as people go forward. We look at healthcare delivery as different from research on clinical trials. Those things have to start figuring out ways to come together. What I'm also saying is it's coming together. We just don't even realize it's happening. It's happening. And it's happening in subtle ways and more. And when you look back and then look forward, then you see how far things have changed. Some things have changed in the right directions. Some things have gotten more difficult, more regulated, more paperwork, more things. And all of us rail against it, but we don't try figuring out ways to solve it, because solving it is very difficult. So I didn't fully answer it, but I'm trying to give you an idea. There are lots of new players who are beginning to see the weakness of the current healthcare players, and they're trying to execute, which means there'll be more pressure on an academic health system to differentiate and ask, what is it an academic health system can do, should do, and complement, just like we talked about AI, how does it complement what others can do more efficiently? And so people are trying to do, we see Kaiser. Kaiser's done a very different model. Since educational systems are not producing the type of people they want, they're building their own. Nursing colleges are cropping up, owned by health systems, which are not part of academic systems. Medical colleges are cropping up, owned by health systems. Why? They don't think we're producing the type of doctors they want. So the people are voting with their feet. That's to keep, so you might like to say, I don't like that, I don't want that. I want it to go back like it was 40 years ago. I would too. Not gonna happen. It's changed and changing, and we have to figure out how to adapt to it or go ahead of it and do it. Because the macro trends are clear-cut. They're not gonna change. Those macro trends I said are clear-cut. It's a question of what an academic institution's strategic plan is to address it. And I've got to say, most academic institutions have not come close to it. And I sort of know because I talked to a lot of them. The reason is we're often in a crisis mode. We have something hitting us every single day, and we have to take out the flames every single day. It doesn't give us the wherewithal to pull out, look back, and do it. But we have to, because there are new players coming in and taking out chunks of what gives us the margins to do things. And I can emphasize that I'm not blaming anything. That's how life is. And we have to adapt. Thanks.